Thank you, sir. Thank you for having me in this IC, and thanks to AIOS for selecting our IC. I think this is the third year in a row we are doing this. So the new toys on the block for instrumentation and vitrectomy surgery. I have no financial interest for this presentation. So we have come a long way from 1921 when we started treating some of the diseases of the retina. We knew that breaks were the cause for retinal detachment and started treating them. It was truly in 1971 that we entered the era of modern vitrectomy when Robert McEmmer introduced the closed vitrectomy system, where a single instrument went into the eye and did all the three jobs: infusion, with suction, as well as cutting. So the later advances, we advanced to 3-port vitrectomy, and then 20 gauge, and then subsequently 25 gauge, then back to 23 gauge, and now majority of the task can be done with 27 gauge, that is just a 0.4 millimeter incision. The vitrectomy machines have also come of age, and these are some of the major machines available. There are many Indian machines also available. The major upgrade that has been is the integrated pressurized infusion. So initially we used to manually manage the bottle height and for the intraocular pressure to be maintained. But now the fluid goes from the bottle into the machine, and the machine gets a sensing from the eye as to the intraocular pressure and then modifies the input of the fluid accordingly so that the IOP is maintained at all times. Most of the modern machines use a combined peristaltic and a Venturi pump that helps in most of the tasks. Vitrectomy cutters are something that have undergone a paradigm shift over time. We have gone from not just the gauges, the 23, 23, 25, and the 27. Also, the ports have moved closer to the end of the cutter, so we can go more closer to the retina, shave more closer to it. Also, the duty cycles, the shave mode, which gives us a more precise control, and even with a detached retina, we can almost touch the retina and cut the vitreous over it. The cut rates have evolved, and starting from something around 2000, we have come now to 10,000, and even the 20,000 cuts per minute cutters are available and in the Western world, and soon we should have them in India too. The bevel tip along with the 10K cutters has been a boon, as that goes along the contour of the retina and again helps in better dissection of membranes as well as the vitreous while we are doing the vitrectomy. This is, I think, something less talked about that Alcon has introduced in the 25 and 27 gauge plus cutters, where this small neck kind of stays in this cannula there, and it increases the strength of the shaft. So the flexibility problems that were there with the initial 27 gauge are not there anymore, and we have felt this while doing retinopathy or prematurity surgery especially. Two-dimensional cutters are coming in, wherein the cutter cuts both while going down and coming back. So this effectively kind of doubles the cut rate that is available to us, and it is available from the DORC, and also this technology is coming into the Constellation also soon. And you can see the turbulence in the vitreous is lesser when a TDC cutter is being used rather than a standard cutter. Hypersonic vitrectomy, that is something coming in. We don't have any personal experience with it right now, but that kind of uses the technology to emulsify the vitreous around it and then suck it in. So with that, they say they can achieve up to effectively 1.7 million cuts per minute. And this was the first in-human trial published last year, where they did some of the simpler cases and showed that, yes, that this was a viable alternative to it. So coming on to the accessories that we have, valved cannulas have been a great boon. They help in better maintaining of the closed system, and especially while instrument exchanges, it is better. Short and long instruments are available from DORC as well as in the Alcon Constellation. With the DORC, they are available with the shorter cannulas also as well as the instrumentation, while the Constellation ones, they use a no cannula system and just the shorter instruments introduced directly. The infusion cannula systems, initially from the suture secured infusions, we have come on to the self-retaining cannulas. They have their disadvantages of slippage also, but still majority of the cases they work very well. Illumination, we have moved on to xenon illumination that is more focused and lesser toxicity in most of our systems. Also, the chandelier system helps greatly in bimanual dissections. The aspirations, both the active as well as the passive aspiration, and the passive both controlled by the atmospheric pressure and by a backflush with the fingers, can be used. Endophotocoagulation probes are available till the 27 gauge, and the curved probes are especially useful. We can even laser up to the ora serrata even in a phakic patient with a slight depression. The endodiathermy and endocryoprobes help in sealing the bleeders, and the endocryoprobe especially helps in posterior breaks in depigmented fundi and also for some indications like hemangioblastomas. Multiple accessories are being taken up, such as the multiple types of forceps, scissors, foreign body forceps, the basket forceps. They all help in multiple tasks. ILM peeling, we are doing more and more, and I think the shark skin forceps from Alcon and the finesse loop are an advantage in this, as they help in creating the edge before we can complete the with ILM peeling. Magnets help with foreign bodies, and they are now available even with 23 gauge that some of us can use through our trocars, and the extraocular magnet for taking out foreign bodies from the outside. Nucleus drops make a major portion of our referral from the anterior segment colleagues, and the fragmentomes help in a closed system management of such cases. The viscous fluid injection helps in the thicker fluids going into the eye through the small gauges, and this same system is now being used as for micro dose injectors in the upcoming gene therapy and also for subretinal injections of other TPA, and we'll be hearing more about that in Dr. Mohit's talk. Visualization, I think we'll be hearing in more detail about the 3D visualization as well as the microscope integrated OCT. I'll not touch upon this. Just a few points on the robotic VR surgery as we are moving into this age now. There are three main concepts for robotic VR surgery that are being purported. The handheld tool just help in reduction of your tremors and smoothen your movements kind of thing. The co-manipulation tools, in which there is an arm that is attached to the side of your operating table and helps you in certain tasks within the whole procedure. And then the telemanipulation, like the Da Vinci system of our general surgery colleagues and neurosurgery, where the surgeon is seated somewhere else and the patient is somewhere else, and the whole thing is being telemanipulated. Co-manipulation is something that has been already commercialized and is available in the commercial market. Herein, we can see the precious system that is there, where this arm is attached alongside the operating table. And once you are done with your vitrectomy and you come to a particular task for which you need the help, such as ERM peeling, ILM peeling, or subretinal injection, you just bring this arm into play, and then you control it with this robotic arm on the side. So this kind of gives you very precise control. Your movements of the hand, the tremors are negated. And also the advantage, you can hold your position in a particular position inside the eye while you are releasing your hand. So that kind of helps with certain procedures such as cannulation of the retinal artery or vein, or even subretinal injections. So the first robotic eye operation was done for ERM in the United Kingdom. So this system is something that is already available. So to conclude, vitreoretinal surgery is an evolving field. Newer advances are being made to make surgery more efficient and safe. I think we are in the prime era of vitreoretinal surgery, and it is important to understand the system at hand completely before we sit on it for optimal outcomes out of it. Thank you very much.